change their pain medications around because they become tolerant or tolerant to one pain medication, so they're going to change it to another because it may work a little bit better. So what they do is they convert the opioid hydrocodone to morphine milligram equivalent, so they know how much to prescribe with the oxycodone. So that's what it means. So 90 MME, if you were prescribing hydrocodone, 1 milligram of hydrocodone is equivalent to 1 milligram of morphine, meaning you can prescribe up to 90 milligrams or more of hydrocodone a day, and you will not exceed that 90 MME threshold. So if you're doing Norco 5 milligrams, that's 18 tablets a day. I hope you are not prescribing 18 tablets a day. That exceeds the acetaminophen requirement or threshold limit. So that's 18 tablets a day. Or if you're doing the Norco 10 milligrams, that's 9 tablets a day. Now, if you're going to do oxycodone, because you're expecting the patient to have more pain, oxycodone is 1.5 times more potent than morphine. All right, so that is equivalent to 60 milligrams, 90 morphine milligram equivalents. That's 60 milligrams of oxycodone. And if you're prescribing oxycodone 5 milligrams, it's 12 tablets a day. Or if you're doing oxycodone 10 milligrams, that's 6 tablets a day. Okay? So that kind of helps you see how much you can prescribe. So what is this patient risk assessment that was highlighted in green? What do you have to do? All right, you must obtain and review the patient's medical history and record and document that you made a good faith effort of doing that. All right, so if you know the patient saw dentist John Smith, in the past, and John Smith has retired, maybe you want to obtain those records to see what's been going on. You must also conduct a physical examination and assess the patient's mental health, the risk of abuse, addiction, and dependency. Yeah.
The full faith effort is so vague.
Yes.
I mean, how long, how many records? Because I can see us in court, doctor, you didn't obtain 5 years records, 10 years records?
So the question is, good faith effort is very vague. What does it mean by good faith effort? Do we go 10 years back in obtaining records, 2 years back? The thing is, there is confusion with that, and the Board of Pharmacy will write regulations to clarify that definition, and we do have a board meeting, upcoming board meeting, I think a week or 2 weeks from now, where we will have some of those definitions.
How about a full physical?
Great question. So what is a full physical? For you as dentists, you are in charge of the neck and up, right? You're not supposed to do a full physical. You do what it is within your scope, okay? And that is good enough. And then obviously you do want to assess the patient's mental health, the risk of abuse, addiction, dependency, utilizing methods supported by peer-reviewed scientific research. There are plenty of resources on the Dental Board website where you can find these peer-reviewed research methods. There's also prescribe365.nv.gov that has a lot of resources to help you implement AB 474. And I'll have those resources listed at the end of my slides. All right, so that is a patient risk assessment. So what is the informed consent? The informed consent is essentially like a pain contract. All right, informed consent is a form, kind of like the intake forms, right? Your patients come in, you give them forms to fill out. It's like another one of those forms, but it is specific to controlled substances, specific to narcotics for treatment of pain. And what has to be on the form are these items, and you must discuss these items with your patient if you are prescribing controlled substances to that patient. Yes?
This is if you're doing a 30-day supply, correct?
No.
Any narcotic?
Any narcotic. Yes.
Any narcotic.
Yes.
So both of these are for any narcotic, the
Yes.
mental health thing, the physical thing.
Yes. Okay.
How do you do a physical examination if it's Saturday night on the weekend and they call you in severe pain?
Saturday night on the evening, and they're calling you with severe pain. How do you do? So,
How do you call in a narcotic?
okay, how do you call in a narcotic?
Physical and or any sort of evaluation.
We can't call in a narcotic that is like hydrocodone or oxycodone because those are all prescription. Yeah, Ultron, Tylenol 3. That's a great question. I don't know what you would do in that case. Yeah, you just don't call it.
You can't call in any narcotics ever
You can if you continue to, like, let's just say that you saw the patient on Thursday and they ran out of their pain meds because they were in excruciating pain, and then Saturday you're prescribing. You don't have to do all this because you already did it on Thursday, so you can call on Saturday.
What the first time they prescribed it to me Saturday, there's no written policy, there's no verbal.
They can go to the emergency room for pain.
They can't call in, it's illegal.
Without doing all these things, having a bona fide relationship, doing the assessment, yeah, you would be breaking the law.
Wow.
Yeah. Okay, good question. All right. So these are the items of informed consent you must review with the patient and must be on the informed consent. The risk and benefits of using a controlled substance, all right? The risk of abuse, things like that. Proper storage and disposal of the controlled substance. Let me just get through this and I'll answer your question. Treatment plan and possible alternative treatment options. Exposure risk to the fetus of a childbearing age woman. If it's a controlled substance that is an opioid, the availability of an opioid antagonist without a prescription, especially for the minors, people under the age of 18. As I gave you some stats in the very beginning of the presentation, they are at a higher risk of abusing these medications. So the risk of the minor and their abuse or misuse and diversion of these controlled substances. Right? These are the items on the informed consent that you must review with the patient before you prescribe the controlled substance to the patient. All right, I have this question first.
It's actually a comment. If you
Sure.
don't mind following up with this.
Yeah.
One of the goals of healthcare nationally is the reduction of emergency department visits.
Mm-hmm.
You just said in that situation we should refer them to the emergency department.
Mm-hmm.
Basically what we're doing is trying to increase the cost and inappropriate use of the emergency room to do that.
So the question is, or the comment was, that there is a whole national goal of reducing ER visits, right? And then the response I gave to this gentleman is, in this particular case, since the patient called and they're in pain, you will refer them to the emergency room. I don't know what else to say. I didn't write the law. I didn't consider all these circumstances, all these different scenarios. There's no way to consider all these different scenarios when you write a law. The only time you hear about it is when the laws are implemented. And so things may change in 2019.
Is that a reg or is that part of the statute?
It's a statute, yeah. So you can't change a statute. It's law. It has to go through a legislative session through a bill. So you have to wait till 2019. Yeah. All right. So that is, oh yes, sorry.
So when the patient goes to the pharmacy,
Mhm.
pays for the prescription and has a consultation with the pharmacist
Mhm.
when the drug is given to them, don't they go through all that?
So the question is, if a pharmacist dispenses this medication to the patient and gives the education to the patient, do they go through all this? They don't. They come in, they drop off the prescription, and the pharmacist, once they fill it, they do give some counseling. They say, this medication can cause drowsiness, don't operate, heavy machinery, but they don't go through the informed consent. They don't go through the patient risk assessment, any of that stuff.
Shouldn't they? Because they're the one giving the drug.
Great question. Shouldn't they, because they're ones giving the drug? Maybe they should.
They pay for the drug.
Yeah, maybe they should. It wasn't written in the bill. I can't change what it is in the bill, unfortunately.
I understand that.
Mhm.
But just like the obligation you have when you give somebody antibiotics
Mhm.
and have a problem with milk, you tell them about that. If there's problems with this drug, causing all these problems
Mhm.
to the patient and addiction and all these things, why isn't it the responsibility of the guy getting paid for the drug to give that to the patient?
I don't know. Great question.
I would think that it's already done in consultation.
All those things aren't done. I'm a pharmacist. We counsel on the side effects of the medication, what to expect from the medication, but we don't do the informed consent, any of that. But if you imagine, if I did go through the informed consent and the patient said, you know what, I'm scared of this drug, I don't want it, right? That is, then I have to refer them back to you. So we got to start it at the source, which is the practitioner, right? Because
Don't they sign that you gave them all this information after they walk out of there? You sign something saying that you gave them a consultation or you refuse a consultation.
yeah, we do that. It's counseling, though. It's not an informed consent form. It's not a physical. We're not performing physicals at the pharmacy. So these are things that we don't do. It's not saying that we shouldn't do them. I'm just saying that the bill isn't written in a way that makes pharmacists do it.
Maybe they could fix
Yeah, 2019. You get your dental association to lobby, to get those changes. I mean, that's possible. But right now, I'm telling you what the law is right now. I'm just here to give you the message, is all.
Is a solution, because really what you're focusing on is informed consent.
Mhm.
You have a bona fide relationship, you've seen the patient before, you've done your H&P or whatever
Mhm.
equivalent of that, but you don't have the informed consent done. So is the answer, if you're doing a procedure that you might anticipate having to write a narcotic, you have them do the informed consent even though you don't dispense?
You can have it where every patient comes in, just does informed consent, and you talk to them about, say, hey, if we have a dental procedure in the future, I may write narcotics, and then it's done. It's an informed consent. You've written it. You've documented that you gave the patient education. The informed consent is to educate your patient the dangers of the medication.
But that covers the legal issue then if you have done that.
Yeah, essentially, there's no unless it is written somewhere that the informed consent expires at 1 week or expires. There's no expiration date that I know of currently on any informed consent. It could be just part of your intake process when you get a patient. All right, so after 30 days, so for some practitioners who are prescribing chronically, right, so this isn't just acute pain, doctors who are prescribing long-term or continually prescribing, after the patient has received 30 consecutive days and you continue to prescribe, these are things you have to consider. But a lot of you guys don't do that, so you don't have to consider this. This is only those who are prescribing continuously. So if you're continuing controlled substance for 30 consecutive days or more, you must enter a prescription medication agreement with your patient, right? And that agreement must go over the goals of the treatment, patient's consent to drug testing, a requirement that the patient take the controlled substance as prescribed and they won't divert it or give it to someone else to take. A requirement that the patient inform the practitioner if they're using any other controlled substances or any illicit drugs, and the not informed consent, the prescription medication agreement must also have reasons the practitioner may discontinue the medication for the patient. So that's at 30 days. At 90 days, these are things that you have to consider and do. You have to determine evidence-based diagnosis, right? Why are you continuing the pain? TMJ, that's my diagnosis, okay? Complete a risk of abuse assessment. Discuss the treatment plan with the patient. I'm gonna continue this as long as you have TMJ. I'm not quite sure. Obtain and review the patient's P&P report every 90 days, all right? So if you're continually to treat the patient, you check the patient every 90 days. If they are receiving a dose, so if you increase the dose and you're now exceeding 90 MME, you want to consider referral to a pain management specialist or revise your treatment plan in the patient's medical record, right? A lot of this doesn't apply to you guys because you guys are treating acute pain primarily. So what is this concept of Prescribe 365? It is confusing. But I'll try to break it down. Prescribe 365 essentially means that no patient should get more medication than they need. So today, if I were to go into your office March 1st and got a prescription for 30 days of hydrocodone, and I go to you, right? And I see you the next day, and you see in my P&P report I got 30 days. Technically, you shouldn't be prescribing to me because I already got 30 days supply. That is what Prescribe 365 means. I shouldn't get 400 days supply of hydrocodone in any 365-day rolling period. Does that make sense? Okay, it's kind of confusing. All right, continuing education requirement. All right, how many hours of CEs must you do per licensure period? You guys get licensed every 2 years, right? So you have to do 2 hours of CE regarding misuse and abuse of controlled substances, prescribing opioids or addiction. And this counts as your 2-hour CE for this next licensure period.
So every licensure period, you've got to do 2 more hours.
2 hours total. So you get licensed every 2 years, so you have to do 2 hours of this type of CE. Yeah?
I had a question regarding the 30 days, and when you're prescribing somebody 30 days of an opioid.
Mm-hmm.
Rarely do we do that 30-day period, but sometimes I'll have a patient, I'll do 15 days,
Mm-hmm.
and then they'll come back in, I'm still in pain, I'll give them another prescription at that point. Do I have to enter an agreement at that point?
No.
So those are two. So I don't have to do it at all.
You don't have to do it at all.
15-day period.
Yep, 2 separate 15-day periods. It's only when you exceed that 30-day, okay? All right, mandatory PNP registration. If you are not already registered for the PNP and you have a controlled substance registration and a DEA number and you can prescribe controlled substances, even if you don't prescribe, you still have to have a PNP account, okay? And you must provide proof to your board during your licensure period to show that you have a PNP registration. All right, and I think the dental board does require you to do that. In addition to that, checking the patient's PNP report, I kind of want to like sum it up. When do you have to check a patient's PNP report? You have to check it if they're a brand new patient to your clinic and you're prescribing a controlled substance to the patient. And if they're not brand new, they're an existing patient, but this is the first time, or you're writing a controlled substance prescription for the patient because they're going through a root canal or something, you just have to check the PNP. And if you continue to prescribe it every month, every 90 days. So essentially, in your guys' cases, all your patients are essentially new, or they're an existing patient and you're prescribing narcotics for the first time. You're going to have to check them in the PNP. Okay? You must pull up the patient's PNP report and review it to ensure that what you're prescribing is appropriate. But the thing is, you can delegate the task of pulling up the report to 2 of your staff members. Okay? So 2 of your staff members can sign up for the PNP, and you can say to the receptionist or to your dental hygienist, oh, I'm going to prescribe John Smith some hydrocodone today. He has a root canal scheduled. Check his PNP report, bring the report back to me so I can look at it. So you don't actually have to physically sign on to the PNP and look it up yourself. They can do that, but you still have to assess the report because you have the license and the qualifications to assess the patient's PNP report.
Quick question on that.
Yeah.
Does the PMP automatically tell you all the states that follow narcotic prescriptions? You have to look at not just Nevada.
The minimum is Nevada, and the patient is, based on what your discussion with your patient. If your patient said, oh, I just moved from Utah to Nevada, I used to see so-and-so in Utah, then you would want to query the Utah's PNP as well. But you don't have to query all.
We were told that we had to query all, regardless of whether the patient gives you any history.
Okay.
I took another course, and they also told us that the physical is a full physical. Anybody that prescribes full physical.
So, it sounds like you're getting information that is different from me versus another person. What I know is you have to just make a good faith effort and query the PNP for whichever state the patient says that they're from. There's no way for you to know if the patient lived in New York if they didn't tell you that. I mean, you have to just make a good faith effort.
23 states that follow? You just include all states? And it gives you the same
You can if you want. You can click all the states that are interconnected with the Nevada PNP, which is about 23, 24 states. We're not connected to all the states, but you don't have to do that. It makes your report a lot slower to generate, but you don't have to do that. But you can to just cover all your bases. You can. Yes.
Do you have to print that report and put it in the patient's chart?
Do you have to print the report and put it in the patient's chart? You don't have to. Every person you query in the PNP, we can see that on my end. I can see everybody you queried, when you queried them, the time you queried them. So it's not required because if in an event you say, I need to know when I queried this patient, we can pull that report for you. Okay? All right. There is also a mandatory use of the PNP in terms of every 6 months. This is an older law. You must do a self-query in the PNP to show that you still have access to the PNP and the information under your name is correct. Right? This is kind of known as a self-query. The reason why you have to do this is because you want to see if there are any fraudulent prescriptions written under your name. A lot of practitioners find fraudulent prescriptions under their name through this process. And then we can then alert law enforcement. So what is the PNP database? For those who are new to it or those who don't know, I did want to give a brief explanation of what the PNP is. The PNP database was implemented in 1997. We've had it for about 20 years, okay? We were the first state in the nation, one of the first states in the nation to have and develop a PMP. Now, 49 states out of the 50 states have a PMP database, except for Missouri. They have a county PMP database. But it's a computerized program that tracks all controlled substances prescribed and dispensed in the state of Nevada. So any pharmacies or dispensing practitioners who prescribe controlled substances, they must upload that information into the PMP within 24 hours, and that information should be available to all pharmacies and practitioners to query. All right, so registering for access to the PMP. If you are not registered, I wanted to provide you with registration instructions. It's fairly easy. It's just these 6 steps. You go to the Nevada PMP website, you click create an account and follow all the prompts, and you should get an account fairly quickly, within about 72 hours if it's over the weekend, but we regularly every morning check it to see if there's any new accounts to be approved. And if there is any missing information, we send you emails with what we are missing so we can get you approved. All right, delegate registering for access. So I did mention you can have up to 2 delegates pulling PMP reports for you. They register the same exact way. A practitioner registers for the PMP, but they register under their name. And there's one additional step where the supervisor has to approve them as their delegate. Okay, it's a fairly easy process. And if you have questions about that, just call our office. We're always willing to help. All right, a PMP search. How do you conduct a patient PMP search? All right, so once you're all signed up and you're able to log in, you go to the PMP site, you log in, and then you'll click on the main menu. Once you click on the main menu, you click on patient requests, and that's how you pull up all the different fields that you have to fill out. All right, once you click on patient request, you fill out the first name and last name of the patient. You can also do partial spelling of their name, so that if you have a really long name, you only have to put like 2 or 3 characters of the first name and 2 or 3 characters of the last name. You have to indicate their date of birth, and then the system automatically queries 1 year of data. You don't have to go further back, but if you choose to do so, you can. You can go back as far as 3 years.